Welcome to the Resilient Performance Podcast. This is Keep It Real Talk number 14. We're going to talk about some manual therapy. It's sort of a common question we get from our students in the clinic, because in physical therapy school, we don't learn too much about soft tissue work, but it's definitely a big piece of the puzzle for how we operate clinically. There's not a lot of research that is behind it, or the research is conflicting. So it's definitely a common question we get with our students. You want to sort of take that and run with it, Trevor?
Yeah, I think a lot of the questions that students come in with, and some of it is based upon whatever experiences they've had, whether it's prior to PT school or other clinicals during PT school, they've been in a clinic that doesn't necessarily do manual therapy. Usually the rationale is that there's no research on it that doesn't show that, that shows that it's effective or anything like that. And I think we always kind of say that's probably not the case, because I think if you have good hands and if you have good manual therapy skills, the symptom reduction that you can give to a client is huge. And I think our number one job, my goal with every person who comes in and sees me is that they walk out better, feeling better than they did when they came in. And I think manual therapy is probably the easiest way to kind of get some sort of symptom reduction, regardless of whatever mechanisms people think manual therapy works under. And I think that's probably where a lot of the misconceptions about the efficacy and use of manual therapy is because there's a lot of really poor tissue-centric ideas of how manual therapy actually helps people feel better. And I don't even necessarily always talk about how it works, but I think if you talk to somebody who has good manual therapy or who has had good manual therapy done to them, almost every single one says they feel better. And I think our goal is always, again, to make patients feel better. So if we're not doing manual therapy, I think we're doing a disservice. And I think another point of view that I always have is putting your hands on somebody and helping them feel better is a great way to communicate with them and to build a relationship with them and to gain trust. So I think if you have good skills, it's not even just the symptom reduction is huge, but there's also building a relationship with the client that you can definitely achieve through manual therapy.
Yeah, it's such a tricky thing to talk about because there's so many avenues I guess we could go with it. But the first one is what are people even calling manual therapy? Because it's become a controversial buzzword in our field. But for example, if someone is very acute and post-op and their protocol only calls for passive range of motion and maybe some low level joint mobilizations, well, then the only thing that they're allowed to do is manual therapy. So if you took a really hard stance and you said I don't ever do manual therapy and you're a physical therapist, well, what are you going to do immediately post-op? Now you could say, well, doing passive range of motion isn't really manual therapy. But what's the line between doing passive range of motion, doing a low level joint mob, doing a quote unquote soft tissue technique? Because the reality is at that point that person's been instructed, you are not allowed to actively contract this tissue, but we want it to move. And so the only way to get it to move is for someone else to move that joint for the patient. So in some ways, there's a lot of semantics, but that kind of is manual therapy. So to take a hard line stance and say, I'm never going to put my hands on somebody, I think is a little bit in some ways reckless, and you're not probably a complete therapist if you say I'm never going to put my hands on somebody. Now, I don't think most people take that dogmatic a stance, but there's a couple of reasons why I think people might oppose it. One of the common things is that they'll say that, patients become dependent on the therapist's hands. They lose their sense of self-efficacy. I just think that's just a bad therapist. If you do manual therapy to the exclusion of anything else, and you're telling this patient that they need to come to you 3 days a week, otherwise they're going to be fragile and fall apart and not be able to achieve their goals. Again, I think it's another extreme position. It's more of a social media straw man. I don't think most physical therapists are that dogmatic one way or the other about manual therapy. I don't think that if you incorporate judicious manual therapy into your plan of care that you're going to create dependency necessarily. I think it's just, and the other thing is most people that are coming to physical therapy are coming for the subjective complaint of pain. Pain is a very subjective experience. So if the subjective experience of manual therapy reduces their subjective experience of pain, then it's hard to say, you can't really say that, well, it didn't work. I mean, again, how do you define what works? What's the goal, and what's the intent of your plan of care? But I think it definitely has a place. And even with manual therapy, like when it comes to controlled trials, like it's really hard to standardize because manual therapy is such an individual experience. And like personally, I like getting manual therapy for myself. But there's a disparity in the experience of manual therapy. Like there's certain people that I've gone to that I think have done it really well, where I left feeling a lot better for the same complaint, and people who didn't necessarily do the same job or as good a job. And again, the good is purely subjective. It's, did I walk off the table feeling a certain way? So there's an element to this that we can't really quantify. And then the other piece of it that I think makes it complicated is like, who is the arbiter of whether manual therapy is useful or not useful? In our healthcare system, we typically rely on health insurance companies to pay for the service. So I think where this becomes an interesting question with any kind of, what we call like an evidence-based treatment is, should health insurance, dollars, in other words, tax dollars or our communal dollars, whether it's for a company or whatever, should those communal dollars be paying for any kind of treatments that don't have great evidence behind them? That's probably the subject of another podcast, but let's assume that it was a much more transparent, like free market type transaction where people were just paying out of pocket for it. To me, if you're willing to pay for it, then it's good because you've deemed that it's worth it. Like I personally would go and pay whatever a really good massage therapist's or manual therapist's hourly rate is to lay on a table and have them put their hands on me for an hour, not think about anything. And there's other reasons beyond maybe like wanting my back to feel looser that I would get it. Maybe it's just the idea of like, look, when in my life do I ever get an hour to lay there and do nothing and be totally free of responsibility and have somebody else kind of responsible for me? So that there's a huge placebo element to that. But the bottom line is like, I'm willing to pay for it. And the bigger obstacle for me getting manual therapy periodically is more time, not money. It's just I don't have the time to do it. But I see value in it, and I would pay for it, and I would take time out of my day or my week to do it. I don't know how often, but like right now, the thought of getting a really good deep tissue massage, like I'm like almost salivating over the thought of it. So again, there's a lot of variables as to why you would or wouldn't use it. But I think, the idea that like anytime you do manual therapy on somebody, you create this like dependency, like manual therapy is the gateway drug to helplessness. I think that's more just that's more of the case of a bad therapist than manual therapy is per se bad. And then there's the other, like the kind of window of opportunity idea where, like manual therapy can create a transient window of opportunity where you reduce symptoms to allow people to move and exercise and have more self-efficacy. I think that window of opportunity thing, there's some legitimacy to it. Again, it depends on the person. There are people, mainly people I think, who are trying to be very, very, take an extreme position on social media to get attention, who will say, that the window of opportunity theory is bullshit and any kind of manual therapy is toxic. Again, I think that's people who just want clicks. That's not real life. I think with anything else, there's a time and a place for a lot of things. And I think that as far as physical therapy interventions go, I think after exercise, manual therapy would be very, very high on my list of things that I think do have a place more so than other modalities, especially like passive electronic ones, especially.
I think what you said, Doug, about like you would pay for it yourself is such a huge sign that like you individually value it. Because I would say I'm the exact same way. Like we spent money on like a sensory deprivation tank once, and like my first thought after we got done with it was like, I wish I had spent that money on getting a good massage, like 10 times over. You know what I mean? It's like if one of the things that you treat yourself with is something like that, it's like there's obviously a reason you want to do that, whether we can really explain it fully or not. It's like there's obviously some value to it that we hold.
Yeah, if it's good for you, it makes you feel good, and you're not hurting anybody by doing it, then like who's to say it's not quote unquote evidence-based or it's not useful for you. That's why we always kind of go back to like the N of one approach with a lot of our patients. It's like, does this help this person right now with this exercise or this manual therapy technique or whatever it is? And yeah, I would definitely say it's like exercise number one, and then number two is going to be putting my hands on people to for whatever the goal is. Typically it's like increasing range of motion, decreasing pain, sensitivity, so that, like you said, you can kind of open up that window so that they can exercise. And I mean, Doug, I think you pretty much touched on like everything you could possibly say about manual therapy. Like you had a lot of awesome bullets there that you just knocked out. But yeah, I mean, it all goes back to like, what are the purposes of why is somebody seeing us? They want to feel better and they want to move better. So however we do that for that one person is evidence-based. And the evidence is in like, okay, well, are they able to do that same thing that they wanted? Like, what are their goals? Can they do their goals now? And then can they do their goals in like 6 months without the requirement of seeing me forever, or in a year or 3 years, 5 years, whatever that is? And to us, I think that's the most important measure of evidence, and being evidence-based is like, we don't need to see this person anymore, and they can do the things they want to do. So I don't know that we see that stuff in research all that much. I think the research is often focused on like, the cellular level, or like, people will talk about like breaking up scar tissue, and like we never believe that. And I would say we definitely believe it's more of a neurophysiological response, going back to like the why does it work sort of thing. But again, it's also like nice to know, and then it's like, who cares? If it's helping people, then we're going to do it, and we're probably not going to stop doing it for the rest of our careers, I would say. And it's definitely a piece of the puzzle that we work with our students on a lot, because it's something they don't really get a lot. You don't get it in school a lot. I mean, I think we got a few hours of hands-on work with our students, with our classmates in a closed environment, going over different sorts of approaches. And I think we actually had more than the typical program at Columbia. And then a lot of students aren't really getting a lot of the soft tissue work in a clinical experience unless they're with us. So when they come to us, they see that we're doing it a lot. And again, it is part of a bigger picture. Like I do more of it than I'm sure I do more of it than you guys do. I just know it, because a lot of the athletes I'm seeing are post-op, and they have a strength coach that's in the same building I'm in. So that's where I fit into their overall, puzzle. That's where I'm valuable for them. If I'm just going to give them more exercises in the physical therapy treatment room with me, when like they're already doing things that are more useful out on the gym floor, that's a waste of their time. I'm not helping them. So it's more a matter of like, how am I fitting into their puzzle? It's not about me. I don't really care. I just want them to feel better and move better and be a better athlete. But yeah, what were we going to say, Trevor? Did you?
Yeah, I think that's a great point you made about like the bigger picture. I think like anything else, it's a matter of triage. Like, what is in your hierarchy of needs? Like, where does manual therapy fit in? Like, I've had people, that I didn't do any manual therapy for during their entire plan of care, and I've had people who like that's all I did, because if I had like, let's say like a chronic pain patient that I think just needs to move, and I've got a finite amount of time, and I'm the only provider they're seeing, and so they can only come in once or twice a week, yeah, I'm probably not going to spend a ton of time doing manual therapy, because I just want them to move, and any movement is good. But I also work with like right now, like a professional bodybuilder where like literally his job is to exercise. So like, and he's also very knowledgeable. I mean, he's as knowledgeable as me about exercise, including some of the things that are more like rehab centric.
So you don't think he needs more exercise? You think?
Right. So like, I'm not going to have him come in for an hour when he's paying me, out of his pocket, and like to do more exercise. So for him, he's like 300 pounds of mainly lean mass. Like, I'm getting getting his body to move manually in a novel way is probably what he needs, and at least subjectively what he reports just makes him feel the best, because he's already doing all the things I would tell somebody else to do with a more exercise-based protocol. He's just like, in our field now, I think we have this. Our underlying assumption is that people don't move enough. And I think that in the variety of cases, most people that we work with, especially general population, don't move enough. So if we can get them to move more, that's therapeutic, regardless of the specifics, right? But when you work with like high-level athletes, bodybuilders, for them, they don't need more movement. So they're the ones that I find tend to benefit more from manual therapy, or at least subjectively report that they're getting a positive experience from it, and maybe it's not the manual therapy itself. Maybe it's just the totally submitting to somebody else for an hour and just chilling out. Like we had Christy Ashwanden, who wrote the book Good to Go, on our podcast a year ago, where she talks about like recovery and the research for recovery. And she's basically like, whatever makes you feel good is what you should do. She's like, I can't tell you what works and doesn't, because you're going there for a subjective experience to feel rested, feel recovered. And I think that manual therapy is very similar. So in that athlete or patient's hierarchy of needs, where does manual therapy fit in? It's going to be different depending on the person's experiences outside of your office. And then the other point you made, Greg, was like, who else are they working with? Because if we're working with an athlete that has a great strength coach, unless they're like really, really acute or post-op, they probably have the exercise part dialed in. So to avoid redundancy, what unique benefit or skill do we deliver that the strength coach doesn't? And oftentimes that is manual therapy, and that strength coach is referring that athlete to us because that's their expectation of what we're going to provide. They know that we trust that strength coach to handle the exercise part. So we're not going to do more of it unless we think that it's going to provide a very unique therapeutic value. And where you work at the Annex, you have very competent strength coaches. So you don't necessarily need to repeat what they're doing in your physical therapy office because they're doing it out on the floor. So again, there's a lot of variables to it, but I think to take an extreme position one way or the other, again, it's dangerous. You're doing the patient and the athlete a disservice if you're not really thinking through like hierarchy of needs and then what's the bigger picture.
Yeah, and it's great because, typically post-op, somebody's like, all right, the typical approach is like, go to this physical therapist 3 days a week, because they're usually not seeing anybody else. So for me, I can see these post-op cases once or twice a week for half the amount of time, because then they're going to just leave my office and go right outside to the gym. And of course, depending on like precautions and contraindications because of the surgery or whatever, then I know that they're just doing the things that they need to do without me, and they're being overseen by somebody who I trust. And then they do have some stuff that they can do at home too. So it's great that they need to utilize me even less, by having that piece of the puzzle covered, so to speak. And then people will ask about like, what about cupping or scraping, or what about cryo chambers? And you bringing up Christy Ashwan and made me think about that too, because there's no like there's no like yes or no to any of those questions. It's just a matter of like, because that's a common question students will bring up too, is like, you guys use your hands a lot. What do you think of IASTM or cupping? And it's like, that stuff's fine. Like everything can work, right? We've spoken about that before. Everything works. It's just a matter of applying it appropriately. But for some reason, and that's all stuff we've done. We've done cupping and taping and scraping, and we just sort of always refer back to like our big rocks, and it's exercise and hands-on, manual therapy, soft tissue work. But again, it's like some people don't like I've had some patients that don't like hands-on work, and they did like cupping, let's say. So it's like, all right, then that's fine. Like that's perfect for that person. And just like Christy would say, it's like whatever's good for that person is what they need. And they're having a subjective experience that gets them where they need to go, then by all means go for it.
I think that idea that like no manual, like all manual therapy kind of operates under the same umbrella of like the neurophysiologic mechanisms takes away this idea that like one cupping or instrument assisted, any of those manual therapies are more special than any of the other ones or work better than any of the other ones. But I think there is that idea out there that like this one manual therapy is the end all be all and is better than the other ones because it has, it has an acronym with it and things like that. But if you kind of just take away that lens and look at it all in more of a general view, I think you can understand that like you're really just trying to give the patient the experience and the sensation that they want, whether it is with, if you're allowed to dry needle, if you only do trigger point, you do trigger point, if you like cupping, you do cup, like whatever it is that person is kind of looking for, trying to give them that sensation to change their subjective experience.
Yeah, I mean, like, I think that there is something unique about therapeutic touch. And even if it's not therapeutic, like how many people have had like a girlfriend, boyfriend, mother, father, somebody just like get behind you and like rub your back or rub your shoulders, like it feels good. So there's something to that. So like, I think, ultimately, like we don't have the answer. I think that we all use our hands way more than we use tools. Like, I can't remember the last time I did any kind of like scraping or cupping, but if somebody said they went somewhere else and they liked it, I wouldn't tell them not to do it. I mean, unless somebody deliberately said like, look, I really want this, like it wouldn't be in my toolbox necessarily, but I do think there's something probably a little bit more profound about therapeutic touch, but just to be a little bit of a devil's advocate, because with any of these things, I don't want to make it like I'm a cheerleader for any of it. It's more like having a discerning kind of thought process to figure out when it's warranted. But like, I think there is a dark side to manual therapy, not so much that people are going to become these like just, dependent addicts to it. But I think a lot of manual therapy, at least from a therapist standpoint, can be a little bit ego driven, where it's like you as the therapist wants to be the reason why the person got better, and you try to make things more complicated than they are. So like a lot of manual therapy techniques, frankly, I think are overly complicated the way that they're taught. It's like, especially with like a manipulation, you've got to rotate this way, side bend this way, when it's like all you're really doing is just finding a novel way for that joint to passively move. And it's like, what made you choose to do that manipulation at C5, C6 versus somewhere else when it probably works non-specifically anyway? So, I think that it sometimes can be a little bit theatrical, where it's like, oh, like I'm going to put you in this position, I'm going to get this cavitation. And again, I'm not against that stuff because I've done it and I do it sometimes, but I think that there can be almost like a guru syndrome, where it's like, I'm doing this because I want to show you how skilled I am with my hands or with this technique, and not because I'm trying to like create a novel sensation or get someone to move in a non-threatening way. So I think that we have to kind of like, always ask ourselves, detach, like, why am I really doing this? And the answer shouldn't be because I'm trying to show off. It should be because I think that it's going to add a unique value or unique experience, not because the technique is complicated. And I think that, like, if I'm being honest, if you're trying to sell manual therapy courses, as with a lot of things in this day and age, like complication sells when simple stuff is what usually works. And I think with manual therapy, it's not like we have this trademarked, patented manual therapy system. It's like we just do shit that we think makes people feel good, and it can literally be anything. So it's unique to the person.
But I think like what I would add to Doug to that is like, I think a lot of, and I would say my problem with manual therapy, and it's not the techniques themselves as much as it is the explanation that certain people give to it. So when I have a client who, it's like, I went and saw so-and-so, or my old PT did this and they put this back into place, or they broke up this adhesion, or they have such a structural approach to it, which I think if you are hearing that over time, that, every time you come in, something's out of place, or this bone's not doing this, or this is stuck, or whatever, it makes people feel fragile. And I'd say that is where the issue for manual therapy comes, is in those explanations that people receive. Like when people ask me like, what's this doing? I'm like, I'm just helping this muscle relax. It feels tight. Me putting some pressure on it is just helping it chill out and not be so tight. It's like, oh, okay. Like that sounds so much better than like, well, there's scar tissue in here and I'm breaking it up because you sat so long. It's like that. I think when the uneducated patient who is told those things all the time, I think that's when there is a huge, like that's the thing, that kind of like pain science approach, and understanding that like what we tell the patient really has an impact that we probably don't see in the moment. It can have more of those like downstream effects is super important. Like, I think de-threatening what we're doing to the patient is a huge key in letting manual therapy kind of help in the moment and help for the long term, so they don't feel like anytime they feel something's out of place. Because if they think every time that their back is sore, something's out of place, it's like, dude, my back hurts regularly. It get tight every now and then. Yeah, exactly. It's like, that's normal. Aches and pains are normal. It doesn't mean like something's out of place. I'll ask them, I'm like, it's out of place. Did somebody like hit you with a baseball bat? Is that what happened? And it's like, oh no, I woke up like that. So then how did it get out of place? Like that doesn't really make any sense when we actually apply those structural explanations to what they're experiencing.
And I remember, Doug has said it before, and I'm going to steal it from him now. Like if you were that fragile that like you could just sleep one way and like all of a sudden your vertebrae is like shifted out of place, like what do you think would happen when you go like lift weights? Like, are you really made of tissue paper where you'll just fall apart? And then like, how do people run? How do people tackle each other and not like explode?
Yeah, and I think, Trevor, you make a great point about there's like this movement in any kind of field or in politics where like people want to categorize those with whom they disagree as like having the most extreme possible position. So with manual therapy, it's like, well, like what you're talking about is the worst case scenario where somebody like just uses explanations that are totally like not supported by any kind of data. But the flip side is like, I could say, well, oh, you like exercise? You must have everybody like, you must have some, a 90-year-old grandmother do squats with 500 pounds. It's like, yeah, you can exercise to the extreme is really bad too. And in fact, you could probably screw people up way more with exercise than you can with manual therapy. Like imagine you took somebody like, Greg, you work with a lot of baseball players. It's like you're 4 weeks post-op, like Tommy John. It's like, let's go throw off the mound right now. That's the equivalent of telling someone that their vertebrae is out of place. Like you can take an extreme position with any of these disciplines or schools of thought, and it would ultimately be kind of ridiculous, right? So I think with any of this stuff, I almost feel weird talking about manual therapy because I don't even think it deserves this much consideration. It's like, it's not controversial. It's like if people just step back from their social media echo chambers and nobody was like watching, it's like, why would you do or not do manual therapy? I think people will come to the same conclusions. Like, yeah, it's not toxic if it's performed by the right people. It's not going to kill anybody. It's not the cure all, but it has, some kind of a place. And the last point is, when people ask me, how does this work or why does it work? Oftentimes I don't even answer. I'll say, I'm going to do it. And you tell me if it worked, right? Because they're going after a subjective experience. So why should we be the ones to bias them and say, well, this is what I think it's doing? It's like, you came here because something felt stiff or you had a little bit of discomfort. Let me just do this thing. And then you tell me if it did anything. Because ultimately that's why you're here. It's like, it's my job to demonstrate value to you, not for me to convince you that what I'm doing, it's not a sales pitch. It's like, you tell me if this worked. So I think if you take that approach where it's like, you're the patient, you're after a subjective experience, you tell me what you think it did, and then we could talk about it after that as to maybe getting into the specifics of how it might work or might not work. But I don't want to bias people and tell them that like, oh, I'm desensitizing your nervous system, because that's kind of like, in some ways it's ridiculous as saying that I'm putting something into place. It's like, do I really know? Do I have a functional MRI hooked up to that person's brain where I can really see what's going on in their amygdala? Like, I don't really know that I'm doing that. That's just like what's trendy to talk about now.
Yeah, the nervous system is king, and everyone wants to talk about that these days. So soon it'll go back to bodybuilding methods, and we'll talk more about muscles one day. But until then, I think we beat this up enough. What do you guys think?
Yeah, I don't think it's that controversial a topic. It's like should you do like unilateral versus bilateral training? It's like, I think life is just so good. We need stuff to talk about.
That's right. I think Trevor froze here, so I will sign off for him. And we'll see you guys next time on the Resilient Performance Podcast. Thank you for listening to the Resilient Performance Podcast. As a thank you for listening, we'd like to offer a 10% discount on our online products, which you can find at resilientperformance.com. We'd like you to use the promo code PODCAST, PODCAST, to get the 10% off. Right now we have the Resilient Movement Foundations course online format for you to purchase there. And we hope to grow that soon before the end of the year and have some other offerings. We hope you enjoy. Again, that's promo code PODCAST, PODCAST, for 10% off. Thanks.